everyone. My name is Emily Romney, and I am the Community Education Manager with the Myotonic Dystrophy Foundation. I am very excited to welcome you to our Ask the Expert webinar today on genetic testing and counseling for myotonic dystrophy. Before we begin, a little bit about the Myotonic Dystrophy Foundation. Our vision is a world with treatments and a cure for myotonic dystrophy. Our mission is community, care, and a cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care. We accelerate research toward treatments and a cure. MDF is here to support you. We have toolkits and publications, which are resources for care providers and families, including our new DM in the Heart Community Guide, Anesthesia Guidelines, the MDF Toolkit, a mental health guide, clinical care recommendations, and resources for clinicians and researchers, including grant funding opportunities for DM research. We also have support groups, which are led by trained community volunteers, and our support programs provide a safe space to network, learn, and share. Additionally, we have our digital academy, which is where you can view hours of educational and inspirational videos by DM experts on demand. You can find all of our upcoming support groups, conferences, webinars, and more on our calendar of events on our website. We would love for you to stay in touch with us. Follow us on social media and make sure you're up to date on all things MDF and DM. You can find MDF on Instagram, X, Facebook, and LinkedIn. Additionally, you can sign up to receive our newsletters from our website. I'd like to highlight a few exciting upcoming events. The MDF 2025 conference will be in Indianapolis, Indiana from May 2nd to the 4th, and community registration for the conference is now open. So you can register for the conference. The first 100 community registrants will be entered to win a fun, exciting race around the Indy 500 track. So don't wait, register now. Additionally, coming up, MDF is hosting a Meet the Drug Developers webinar with Artex Biotech on October 4th, and you can register now to participate. I'd like to thank our sponsors of this webinar, Avidity Biosciences, for sponsoring our Ask the Expert webinar series. Thank you for joining us today from around the world. Today's program is an Ask the Expert webinar, which features a presentation from Shawna Feeley, followed by time for a Q&A. We do ask that you use the Q&A function to ask any questions, and they'll be sent directly to Ms. Feeley. We will do our best to answer as many questions as we can. To ask questions, click the Q&A button, type your question into the text field, and click Send. You can also send questions anonymously if you prefer. Without further ado, I am pleased to introduce Shawna Feeley. Shawna is a certified genetic counselor at Seattle Children's Hospital, specializing in neurogenetics and neuromuscular disorders. She has worked with families affected by genetic diseases of the nervous system for almost 20 years. Her role includes helping families navigate the process of genetic testing while providing support and education about their diagnosis. She also has combined her clinical role with research and helped with gene discovery programs and natural history studies. She has developed multidisciplinary care centers for people with neurogenetic neuromuscular disorders at Wayne State University and the University of Iowa. She joined Seattle Children's Hospital neurology team in 2022 to build a neurotherapeutics program, which provides guidance regarding targeted therapies and medical management to families with genetic determined neurological disorders. She's happy to have joined a great team and looks forward to continuing to partner with patients and families affected by these conditions. So I will now turn the time over to Shawna.
Thanks, Emily. So I'm happy to be here today to kind of chat about what genetic counseling is and also genetic testing for myotonic dystrophy. To start, I wanted to go over what is genetic testing and kind of do a review of our genes. Next slide. So when you think of our genetic information, you can kind of think of it as our recipe. So when you're cooking at home, oftentimes we are following a recipe, and the recipe gives information about how to bake a cake or make whatever you're making. And similarly, our genetic information helps our cells to build what we call proteins. So these are essential proteins that our body has to make to be able to build the cells in our body. And so our cells are reading this recipe, this genetic information, and knowing what they're supposed to do and how they're supposed to do it. And this recipe uses a very simple alphabet of A, C, T, and G, so just a 4-letter alphabet. And that alphabet helps to spell out to the cell what it needs to make. So when we're doing genetic testing, we are looking through these sort of genetic words and seeing if there's a change that might lead to a genetic disease. Next slide. So I said that this is a very simple alphabet of just 4 letters, but it is actually a very complex and large amount of genetic material that helps to build all the cells in our body. So if you were to print out the entire human genome, you would see that it is a huge amount of data that our cells have in every single one of our cells. And if you look individually at the different colors of these books, in just the yellow books that are printed out here that this group did, that's just one chromosome of data. So this is a very complex, large amount of data that our cells individually have in order to build everything like our eye cells, our skin cells, and even our muscle cells, which becomes important in myotonic dystrophy. Next slide. So again, all of this data is held in structures we call chromosomes. So chromosomes are just packages of genetic information, and the cells are able to unravel that and read it and know what they're supposed to do and how they're supposed to do it. So it really gets back to these instructions and whether there's changes in these instructions that could lead to a genetic disease. Next slide. When we look at chromosomes, it's easy to look at them in a kind of picture like this, which we call a karyotype. That way we can see that all the chromosomes come in pairs, and we get one of each pair from mom and one of each pair from dad. Like that's why we look a little like mom, a little like dad. When we look at chromosomes like this, people who are born female have 2 X chromosomes. Next slide. And people who are born male have an X and a Y chromosome. So that's the only difference. The first 22 pairs of chromosomes are the same between people born male and female. When we look at the gene for like myotonic dystrophy, it's located on chromosome 19. So again, the same between males and females. For chromosomes, they have many, many genes on each chromosome. So the genes are located on the chromosomes, and each gene has a code that is spells out to the cell what it needs to do. This genetic code is captured in 3-letter genetic words. So you can see the code here, ATC, CAG. Each of those is a 3-letter genetic word that's telling the cell to make a specific amino acid. So each 3-letter word codes for a specific amino acid. Those amino acids are then strung together like beads on a string that make the proteins that function in our body. So when we're doing genetic testing, we're looking to see if there's changes in that genetic code that could be changing the function of that protein. Those changes could be a spelling change, for example. So some genetic conditions are caused by a change or like a letter change. So a G changed to a T, which may change the protein shown in the next image. So here, as I mentioned, the G was changed to a T, and that creates a different amino acid and thus changing the protein's function. In other genetic conditions, we might have things like a deletion, for example. So that's shown here, where a specific area of the gene is missing, and that can also result in an abnormal protein. So there's tests that can help pick up deletions or even duplications, extra words or letters that can lead to a change. Next slide. For myotonic dystrophy type 1, as I mentioned, that's located on the gene responsible for that is located on chromosome 19, and the gene is called DMPK. For people who have myotonic dystrophy type 1, it's a dominant condition, so you only require a change on one copy of that gene in order to show symptoms. And in that case, you would have a 50% chance or a 1 in 2 chance of passing it on to each of your children. Next slide. So this is caused by a different type of change in the gene that we call a repeat disorder. So every single one of us has a repeated genetic word in their DMPK gene. This repeated word is CTG. It's supposed to be there, but it's only supposed to be repeated a certain number of times. So we consider myotonic dystrophy a repeat disorder because people who have that repeated genetic word repeated too many times leads to symptoms. But when we're doing genetic testing, in this case, we're just counting up how many of those repeated words there are, how many of those CTG repeated words there are. And if it meets a certain cutoff, then that leads to that person to both have myotonic dystrophy and be able to pass it on, have a 50% chance of passing it on. However, that repeated genetic word is not what we call stable. It can change from generation to generation. And it is linked to the age of onset that a person has. So the higher the repeat, the earlier the age of onset. That's why you see people in the next generations sometimes having an earlier age of onset than their parents. We roughly use this table as a cutoff. It's not an exact science, but we say that individuals there who are mildly affected are in the range of 50 to 150. Sort of the classic onset is in the range of 100 to 1,000. And then you have children or what we call infants who have congenital myotonic dystrophy, and that is in a range over 1,000. Some labs report these numbers and some labs don't. So you may not always get a report that has your exact number on it. And this number is not necessarily always the same in every cell of our body. And sometimes when you do genetic testing with blood or saliva for this type of testing, you might pick up different numbers. And so we describe it sometimes as being a spread where someone can have 10,000 to 15,000 or something like that. So these numbers can get very big. And even within a couple generations, someone can have a child that is affected by myotonic dystrophy. But you don't always get just one specific number. And there are people who have what we call pre-mutations. So these are expansions between 35 to 49 repeats. They're considered expanded because they're higher than what we would typically see. But that person may never show symptoms of myotonic dystrophy. However, they still can pass myotonic dystrophy on because when they pass that expanded number on, it's not necessarily stable, and that's where it can get bigger in the next generation. So that's where you see families who have no family history and then have children or next generation has myotonic dystrophy. Next slide. So as I mentioned, the CTG repeat number can expand. It can also contract. It can get smaller, or it can stay the same from generation to generations. And even like brothers and sisters may not have the same repeat number. It often expands when it's coming from a mother. It just tends to be more unstable from mom, and so we call that process maternal anticipation. There are other repeat disorders for other genetic conditions where the expansion comes more often from a father. So there's just different patterns that we can see. And myotonic dystrophy is a condition that expands more often from mom. The higher the number is, the earlier age of onset, and the more unstable that number is. So the more like kind of different numbers you could get in your cells. You can get myotonic dystrophy from either mom or dad. And I hear that a lot of confusion sometimes in families that I'm working with, that people think it only comes from mom. I think that's because of the maternal anticipation, and people sort of don't realize that, but you can get it from mom or dad. And people born male or female can have myotonic dystrophy. Next slide. So this is just a picture of what we call dominant inheritance. So that individual, so the parents are on the top, and you can see that one individual has a red bar representing the change, the expansion. So in this case, they would have a 50% chance of passing on that red bar, because they're either going to pass on the chromosome that's healthy, working, no red bar, or the one that has the red bar on it, which again represents the expansion in this case. For dominant inheritance, the partner doesn't matter. So the other partner is unaffected, but that doesn't matter in this case. If someone inherits that red bar or that expansion, then they're going to develop symptoms. And so there's a 50% chance or a 1 in 2 chance of passing it on for each pregnancy. And just because you have traits or look like your affected parent does not mean that you are definitely going to have it. Our traits are inherited differently than these genetic diseases, although there are some things that can be linked to myotonic dystrophy and may kind of have a longer face or some balding on the forehead, things like that can represent someone who has myotonic dystrophy. Next slide. So when we are, as genetic counselors, we use a tool called pedigrees. So if you see a genetic counselor, we would often sit down and draw up a pedigree, which is basically a family history where women are represented by circles and men are squares. That's just the way it is. So sorry, men, you're squares. But in this case, we see a person who's at the top, who's kind of shaded in blue. They don't have any symptoms, but they have a repeat of 49. So they're kind of in that expanded area, what we call a premutation. So they had a 50% chance or a 1 in 2 chance of passing that on. And we see in the next generation, the person inherited that expansion, but it changed, the number changed. So it went to 112. So it's bigger. So what we call that an expanded repeat. And they started to show symptoms later on in their 40s. They, again, would have had a 50% chance of passing it on to each of their children. That starts over each pregnancy. And so 2 of their 3 children inherited the expansion. And again, that number changed in one of the children getting larger to 345 repeats. So they started showing symptoms around 20 years of age. And then that individual had a child who had repeat number in the thousands. And so that's how within a couple of generations, we can see someone who had an adult age of onset myotonic dystrophy and someone who has a child who's affected. Next slide. These are the classic hallmarks of symptoms that we see. Muscle weakness being the main one. Myotonia. Sometimes people can have early onset cataracts or frequent cataracts. And for some people, cataracts are actually the one symptom they have if they have like a mild or low repeat number. Cardiomyopathy just refers to problems with the muscles of the heart, because our heart is also a muscle. Like I mentioned, sometimes people can have frontal balding, so balding around the forehead area. Gonadal atrophy is another sign, along with sometimes hormone changes like diabetes can be a risk, things like that. And then sometimes when we see a congenital or earlier onset myotonic dystrophy, that can lead to learning delays or intellectual disability. As we mentioned, it's dominant and has maternal anticipation. So we see this pattern where oftentimes where a mom may have a milder form and she may pass it on and then have more severe disease in subsequent generations. I think one of the questions that came in was related to, is it good or bad to have the repeat number reported? Like, as I mentioned, some labs report that, some labs don't. Sometimes people find it helpful to know the repeat number so that they can estimate the risk of having a child with congenital myotonic dystrophy. So it kind of helps to interpret what that risk is. But as I showed you the table with the cutoffs, but they're not really super clean. So some people can fall into a different range and have more severe symptoms or less severe symptoms, and we don't quite understand why. So that's why sometimes labs don't report the cutoff, the repeat number, because it's more based on the clinical symptoms that you have and how the neurologist or the person evaluating you would describe those symptoms. Next slide. With myotonic dystrophy type 2, this is on a different gene on a different chromosome. So this is on chromosome number 3. This is the CNBP gene. Next slide. It is still autosomal dominant, so same pattern. The cutoffs are slightly different. And the CCT, it's a different type of repeat. It's a CCTG repeat size, which increases with age. And people can have 2 or more CCTG expansion sizes detectable in blood. Next slide. So this just shows the same pattern of inheritance. If you have the expansion, then you have a 50% or a 1 in 2 chance of passing it on to each child. Next slide. And the cutoffs are a little bit different in that they don't necessarily, there's not necessarily a link to earlier age of onset with repeat size. So there's a little bit different information that goes with the repeat size. When we talk about genetic testing, oftentimes we're talking about it in the context of genetic counseling. So these are 2 different things. Genetic testing is the actual test that you're doing to determine if someone has a genetic condition or not. Genetic counseling is a process where you meet with a specialist, a genetic counselor, and that individual helps families and individuals understand the genetic effects that affect their health and their lives. So we go over, we help people understand their genetic risk. We explore tests that might be the right test for each person. And we help people understand what genetic test results mean for them or their families. So this is an individual like myself who's professionally trained in both medical genetics and counseling. And when you see a genetic counselor, it doesn't always mean that you're going to get genetic testing. Genetic counselors go through the pros and cons of a test and help people decide whether they want to get a particular test. So our role is to help guide people through the testing process. We facilitate the most cost-effective approach to testing based on their insurance and stuff like that. We identify the most likely way to get informative result. So in the case of, for example, myotonic dystrophy, that's a specific test that you would want to do that identifies a repeated genetic word. If you're doing sequencing, which is looking at the spelling, you're not going to detect myotonic dystrophy. So you want to make sure that we're picking the right test for the right condition. We review the pros and cons for testing, and we help patients make an informed choice. So this is a very patient or family oriented specialty where we lay out all of the pros and cons of a genetic test, and that individual makes an informed choice for themselves. So not everyone I see ends up getting genetic testing. Each person is making that choice for themselves. And then we help once testing is set up, if that's what the individual or family wants to do, then we help to interpret those results and explain what they mean. Next slide. There are different types of genetic testing. So confirmatory or diagnostic testing is when you have an individual who's already showing symptoms. We believe they have a certain condition, and we're just doing genetic testing to confirm that that individual has, in this case, myotonic dystrophy. Predictive testing is where you have a family history of a known genetic disease, and you are offering testing to see if someone is going to develop this condition in the future. So that's where, for example, if we had an adult onset myotonic dystrophy in the family, like in a parent, and an individual says, I would like to know if I'm going to have this in the future as well. And so they currently don't have symptoms, but they want to go and see a genetic counselor and get testing to find out if they're going to have this in the future. Prenatal or preconception testing is for the purpose of family planning. So that is an individual who is making decisions about testing during or before a pregnancy for the purpose of not passing these conditions on to the next generation. Next slide. As I mentioned, we go through a lot in genetic counseling about the pros and cons. So genetic testing pros, in this case, is to determine if other family members are at risk. So if an individual has clinical signs or is presenting with muscle weakness, things like that, they may want to get genetic testing so they can know if their children or other siblings may be at risk for a genetic disease. It can also mean access to treatment and screening along with clinical trials. So access to treatments such as physical therapies, things like that, and screening. In myotonic dystrophy, we can have concerns related to heart concerns, and it's important to have those types of things screened because they may be manageable or treatable. So although there's no cure for myotonic dystrophy, there may be a diagnosis can lead to access to some of these things that may be important for management. Clinical trials are kind of an amazing area of research that's going on for myotonic dystrophy in terms of gene therapies. There's several different important clinical trials that are going on. And so sometimes people are getting involved in those trials, but need a genetic test to confirm their diagnosis, as well as natural history studies, which allow us to look at how people who have myotonic dystrophy change over time. And those are important for those gene therapy trials, things like that. Sometimes people just want to have a definitive diagnosis. They have symptoms going on and they just would like to know, what do I have? Why is this happening to me? And then there's family planning options, but it requires a genetic diagnosis. So if we know that genetic diagnosis, then there are ways to prevent passing it on in future generations. Next slide. So family planning options include if you would like to have, for example, your own biological children, there is testing that can be done during pregnancy to detect myotonic dystrophy. So this can occur as early as 10 weeks in pregnancy if you're looking at chorionic villi sampling, or an amniocentesis is slightly later than that. That's where you're taking out fluid that surrounds the pregnancy and testing that fluid for the expanded repeat. So if you're testing during pregnancy, then if the pregnancy is affected, you would decide whether or not to terminate that pregnancy based on that information. Before pregnancy, there are options such as pre-implantation genetic testing. PGT is what it's referred to now. And that's where you would use the same technique that couples use when they have difficulty getting pregnant, IVF. So you take the egg and the sperm outside the body, create an embryo, and then you would test that embryo at the around 8-celled stage. So you take one cell off that embryo, test it for the expanded repeat of myotonic dystrophy. It doesn't affect that embryo at that stage. And so then you would only implant healthy working embryos that are not affected by myotonic dystrophy in mom to continue on with a regular pregnancy. The entire process of IVF costs around $20,000 to $25,000. So that can sometimes be cost prohibitive. Other family planning options include donation or adoption. So donor options include sperm donation or egg donation, depending on whether this is from mom's side or dad's side. So you would, the sperm donations are pretty cheap. Egg donation is more expensive. And then there's also a process called embryo adoption. This is where couples have utilized IVF to conceive their families, and they're done growing their family. They don't want any more children, but they still have embryos left. You can adopt embryos for a cost to have those implanted so that you can have the experience of going through a pregnancy, even though you're not biologically related to that child. And then there are also traditional adoption options. You can see that these costs these range in costs, and these are estimated, but yes, all of these processes can to varying degrees cost a significant amount of money. Next slide. So genetic testing cons, in this case, genetic testing can sometimes lead to an emotional impact on the family system of even positive or negative results. So sometimes we see families who want to go through testing because they have a parent who is identified as having myotonic dystrophy, and a child can test negative, meaning they're not going to have this, and they can sometimes experience a level of survivor's guilt. So maybe they feel bad because the other members of their family tested positive and they tested negative, and they're not going to have to experience those symptoms that their family members have. So positive or negative results can sometimes impact a person unexpectedly. And so it's not always a happy moment when someone tests negative for something that's in their family. When we look at testing children, that can be a complex question. When do we approach genetic testing for children? A lot of families, these are adult onset conditions, and so there's questions related to when would we test a child, at what age? If we're talking about testing children, oftentimes we're waiting for them to become have the ability to consent for themselves. So at the age of 18, they can legally consent. However, so we know that sometimes children can start to show symptoms earlier than that. So it's really a complex decision to make, and there's a dialogue or a conversation we have with the family and the parents to make sure we're doing the right thing for those individuals. We know that people have concerns about genetic discrimination. Genetic discrimination is when people's genetic health is used against them in terms of their access or ability to access things like different types of insurance. And there can be concerns about cost for testing. Although the genetic test compared to other genetic tests, genetic test for myotonic dystrophy is considered to be fairly inexpensive. It can be done around $250 to $300. It depends on the laboratory. There's labs that cost a lot more than that. So we base it on, the type of insurance, what your insurance, which laboratory is partnered with which insurance and how to get coverage for that, things like that. But if you're being told that your out of pocket will be much more than that, you might want to consider asking your provider if there's a different laboratory you can use. Next slide. So going back to genetic discrimination, there is a federal policy called GINA, the Genetic Information Non-Discrimination Act. And for people who are at risk for a genetic disease, this is our protective policy. So what GINA does is it protects people's health insurance and it protects people's employment. So if you have a family history of a genetic disease or you are tested positive but don't have symptoms, GINA is the entity that's going to protect you so that even if you're diagnosed and have a positive genetic test, that cannot be considered a pre-existing condition, so that you can transfer from one health insurance provider to another, and that information can't be used against you. It also protects your employment, so that information can't be used for hirings, or access to raises, things like that, as a part of your employment. What GINA does not do is that it does not protect for life insurance, disability insurance, or long-term care insurance. So if someone is not showing symptoms, these are for people who are asymptomatic, but they have a family history of myotonic dystrophy, and they decide they want to go and get testing. If they test positive, that could impact their ability to get these types of insurance in the future, because myotonic dystrophy can be life-shortening. A life insurance provider, for example, may take that information and say, we do not want to cover you because you're positive for myotonic dystrophy. So some people decide to get these types of insurances before they move forward with testing. And this is something that genetic counselors would often review before we actually do any testing, is to go through these. These are a lot of times commercial payers. So like a life insurance policy that you would get above and beyond what you get from your workplace. So there's not usually a lot of back and forth between your insurance that's provided from an employer. But if someone wanted to get a life insurance policy beyond that, they may have to apply. They may have to fill out a questionnaire, and that questionnaire may ask questions about genetic health. Or sometimes the insurance provider asks you to sign a consent form, giving them access to your medical records. And in that context, that's when they might find out about a genetic test that you had that indicates that you're positive. There are also some other limitations to GINA in that it doesn't protect some groups of people. So it doesn't protect people that are members of the military, and it doesn't protect people who are already manifesting a condition. So when you already have muscle symptoms or symptoms of myotonic dystrophy, and you've had a genetic diagnosis, HIPAA is the protector in that case. Next slide. So HIPAA is one of those that helps our privacy. So a lot of times when you've gone to your doctor or whatever, they have you sign a HIPAA form saying that you are, everything is kept confidential, which is true. But HIPAA protects people who have a specific condition, so that it can't be considered a pre-existing condition if that person hasn't been treated for that in a certain number of months. These things can be changing based on federal law and policy. And so we know that these things change over time. But HIPAA is the entity that protects people who are symptomatic of a current disease. Next slide. I wanted to include some helpful websites for people to access. So clinicaltrials.gov is a great resource. You can go on and type in myotonic dystrophy or a particular condition and search, and it will show you all the clinical trials that are going on. So this is a great way, along with the Myotonic Dystrophy Foundation, to find resources about maybe an active clinical trial that's near you. There's a lot of great information resources. So the CDC also has genetic resources about genetic conditions. There is another website called Concert Genetics. This allows you to compare laboratory prices and compare tests. This is a resource that a lot of genetic counselors use. And then to find a genetic counselor near you, there is the National Society of Genetic Counselors website. So that's a way to find someone that's in your community who you can go and talk to about testing and your testing options. Next slide. Genetic counselors work in many different specialties. There's preconception genetic counselors. So those are people that you would talk to if you're deciding if you want to move forward with having children and you want to pregnancy plan. Prenatal genetic counselors are you're typically working with when you're already pregnant. You can whip through these. These are all the different specialties that you might find a genetic counselor. So pediatric genetics, genetic counselors work in laboratories. There's cancer genetic counselors, cardiovascular genetic counselors that work with hereditary heart issues. Sometimes folks with myotonic dystrophy, because of the heart concerns, they might be diagnosed in a cardiovascular clinic. Neurology is the most common place where we see folks with myotonic dystrophy. So neurogenetic or neuromuscular conditions, that's my specialty. And then we also work in research. And as I mentioned, the NSGC website is a great place where you can search for your local genetic counselor. Next slide. And that's all I have. So if we want to open for questions.
Thank you, Shawna, for that informative presentation. As Shawna mentioned, we'll now transition to the Q&A portion of today's webinar. And just as a reminder, we ask that you use that Q&A function to ask your questions, and we will see them directly. So we will do our best to answer as many questions as we can. And to ask questions, you'll click that Q&A button, type your question into the field, and click send. You can also send questions anonymously if you prefer. So we will now open the floor up for questions from our attendees. I also have a list of pre-submitted questions from folks who submitted questions upon registration. So I'm going to go ahead and kick us off with some questions, and I'll keep an eye on that Q&A function as questions come in as well. So the first question that I have for you, Shawna, is can someone get better treatment if they get a diagnosis? Is that a pro to getting a genetic test and getting that diagnosis confirmed?
If someone is showing symptoms of myotonic dystrophy, then there is an importance in actively screening for things like heart concerns, as well as some of the challenges that people can have with hormone regulation and diabetes and things like that. And even for things like the muscle weakness, there can be devices or physical therapy that can help with management. Getting a diagnosis often leads to all of these things. You need to know what condition you have, because there's many different types of muscular dystrophy. And depending on the type of muscular dystrophy, that may direct you towards one pathway for screening or another. And so I would say yes, that a clinical diagnosis with someone who is actively having symptoms is an important step in order to have a pathway for those management options.
Yeah, that makes sense. Thanks, Shawna. My next question is kind of in regards to insurance concerns, which I know you talked a little bit about. But someone had a question regarding if they already have, let's say, health or life insurance, can getting a positive test increase health and or life insurance premiums?
So, as I mentioned, with under GINA, health insurance is protected. We guide people towards group policies rather than individual policies because that protects them a little bit even more. But in general, your health insurance should be protected. The tricky part is with life insurance. So some people have existing policies, but if you change that policy, if you're trying to like put more money into it or things like that, sometimes that can also trigger the life insurance policy to either do a case review, or they say if you were diagnosed within a certain amount of time, we can, of altering this policy, we can still drop you from this policy. So I guess I would say read the fine print, know if you're making any adjustments to those policies, what the impact could be in terms of, your genetic health impacting your ability to maintain that policy.
Yeah. Okay, great. And I mean, you mentioned reading the fine print and kind of some of these things around the order in which you may want to go about doing some of these things, but do you have any other advice for navigating insurance coverage while trying to get genetic testing?
So when people are doing genetic testing, as I mentioned, sometimes people want to set those policies up prior to doing the test. I would make sure that policy, sometimes they have a little window where they say if you're diagnosed with something within 60 days or 120 days of setting up this policy, we can still drop you. So I would make sure that if you set up a policy, you don't have that window attached so that you can get genetic testing free and clear after you've set up that policy. There are some commercial policies that ask a lot of questions related to family history. So typically someone with myotonic dystrophy is going to have a family history of myotonic dystrophy. You want to avoid insurers that are asking a lot of questions related to family history and are more focused on your personal health history.
Okay, great. Thank you.
Mm-hmm.
My next question for you is, why should someone get tested if there's currently no cure for myotonic dystrophy?
I mean, that is a good question to ask a genetic counselor that you're working with. And that's why genetic counselors exist. That's why our specialty exists, to go through those pros and cons. Certainly, we see importance if someone's actively showing symptoms, because there can be management recommendations that come with this, especially related to management of the cardiovascular health of heart, because that is a life-limiting part of this disease. And it's important to have screening and have a cardiologist involved in your care management. If you're talking about predictive testing, that's a whole different situation. And again, yes, there's pros and cons. It depends on that person's situation, if they're actively family planning or other things that go into that decision. And so this is why we have these conversations, because it's not a one-size-fits-all approach. And I would not say that everyone should go out and get testing for myotonic dystrophy. It really depends on each individual's situation.
Thanks. Yeah, that makes a lot of sense. Okay, my next question from an attendee is, in light of scientific advancements, if you were tested for DM years ago and had a negative result, should you get tested again?
I guess it depends on if that test was related to a known family history that was diagnosed. And what I mean was a family member genetically diagnosed with myotonic dystrophy, because we know there are hundreds of different types of muscular dystrophy. And so, you would want to make sure that you're testing for the right thing. It's, we have identified new genes in the neuromuscular world all the time. And so if someone was thought to have a muscle disease and had negative myotonic dystrophy testing, but we don't know if that's the correct test for them, you might want to explore a different test. But in general, even if you had myotonic dystrophy testing years ago, if you know that that's the genetic cause in your family, and that's the correct test to do, and it's negative, it's not necessary to keep repeating that test.
Great. Yeah, that makes sense. Okay, my next question for you. This person says that they will be the first to be diagnosed in their family with myotonic dystrophy type 1. They're planning to see a neurologist soon, and they asked if they can just ask their neurologist to test them for DM.
You can, if someone's already showing symptoms, a neurologist may do genetic testing. I would add that sometimes it's beneficial to see a genetic counselor to go through all the pros and cons, like I was talking about, which in my experience, neurologists may not address those types of questions. But particularly if you're doing predictive testing and you are deciding whether to get testing, a genetic counselor would be very informative to help you make that decision. So there are different ways that people get tested. They don't always see a genetic counselor, but if you have any of these questions, a genetic counselor can be a great first step.
Yeah, great. This person asks, what are the options for people to get a DM genetic test if their doctor or insurance says no?
There are many laboratories that can offer genetic testing. And so it may be that working through your insurance with a different laboratory would allow you access. As I mentioned, the test itself is, can be around $250 to $300 depending on the lab. So wouldn't be too expensive to pay out of pocket, although not everyone can access that amount of funds for a test. And with genetic testing, sometimes a physician who is not experienced at ordering genetic testing may feel overwhelmed. They're not sure how to order or interpret genetic testing. And so reaching out or accessing your resources, your local resources, such as the NSGC website that I mentioned, and finding a genetic counselor might be appropriate in that case, because they may be able to help walk you through why a test may or may not be appropriate for you and how to get coverage through your insurance. So we write letters of medical necessity to get coverage. And one of the negative parts of my job is fighting with insurance, but we aid in that process as well to make sure that you have coverage moving forward. So that can be another reason why a genetic counselor can be helpful, is because we are used to navigating the insurance and coverage for genetic testing.
Yeah, great. Okay, another attendee asked, is there a difference in cost between the DM2 test and the DM1 test for diagnoses?
Yes, there can be. There's differences in these tests in terms of complexity. There's different labs that will do DM1 versus DM2. DM1 is very much more commonly done. So you want to make sure you have a lab that's certified to do that test, that you need to make sure that the sample type, the lab is certified to use that particular sample type. So some labs might only be certified to do blood samples versus buccal swabs in the cheeks. Saliva samples is another way we do genetic testing, but each laboratory may be only approved to do one of those sample types or one of those conditions. So again, not to keep saying this, but genetic counselors help people navigate all of those test types, what's available, what lab is certified to do that test. And so those are kind of the things that you would want to look at.
Yeah, great. You mentioned the saliva test, and we did have a question regarding that. They asked, will a saliva test give trustworthy results to positively diagnose someone with DM2?
It again goes back to whether or not that lab is certified to use that sample for their methodology. So you would need to look at the sample and whether or not the lab accepts that particular type of sample. With both DM1 and DM2, there are labs that can use saliva or swabs, but not every lab offers that. And the reason is more, it's not related necessarily to accuracy, is more as like how much volume of DNA that you get from samples. So like a blood sample, you're going to get more DNA than saliva or buccal swab. And so when you're doing testing, if you don't have enough DNA from that sample to extract, we've had patients who, for example, submitted a buccal swab, couldn't get enough volume of DNA. So you essentially have a sample failure because there's not enough volume to run that sample. So it's less related to accuracy, and it's more whether that test is going to be able to be run or if you're just going to have sample failure. So I've arranged testing where you do a buccal swab, you have a sample failure, then that person has to come in and get a blood draw anyway, for example.
Okay, yeah. And kind of a follow-up to that, you mentioned these labs, only being certified to perform certain tests. How would someone go about finding these verifications? Are they easy to find? Are they on the lab's website, or are they things that someone from the community might need to get from their medical team to confirm which types of tests these labs are certified to perform?
Well, it's easiest for people in the general population to meet with a genetic counselor or provider, and they should be the ones navigating that for you. But the website that I provided, Concert Genetics, is another way to compare laboratories. And on the lab's website, they should provide sample instructions for each test. So when you go in, you can go into a particular lab, search for the tests that you want, see if it's something that's available at that laboratory, and then they'll have sample instructions. They'll always have a preferred sample, which typically is blood, but then they'll go through some of the alternative sample types.
Okay, great. Thank you. All right. Someone else asked, for DM2, does the repeat number matter?
Not as significant as, it matters in terms of diagnosis, but it's not as significantly impactful to things like our knowledge of age of onset, and the expansions are not necessarily tied to the earlier age of onset and things like DM1.
Okay, great. Someone else asked, is it sufficient to get a genetic test that gives a yes/no answer in terms of diagnosis? For example, some laboratories will just let you know if you have over 150 repeats, but not tell you how many.
It depends on what your question is related to that testing. If you just want to know if you have myotonic dystrophy or will have it in the future, a yes/no is a fine, interpretation of that. And many labs will just provide, yes, this person has the expansion or not. It's sort of an ongoing debate about whether people should or need to have that repeat number exactly. There is some information that it can provide, like your risk of having, particularly for a woman, the risk of having a child with congenital myotonic dystrophy. So obviously, if the mom's repeat number is higher, that can be helpful to know, because then it may impact that risk of severity of her children and condition and the disease. But it's sort of an ongoing debate whether it's informative or it just provides information to families that are like not necessarily accurate. So people may do the test and think they're going to fall into a particular range of disease severity or disease onset, but that's not always the case. And so that's why sometimes labs just report yes or no. They don't disclose that repeat number. I think that if people are counseled appropriately, that it's not an exact number to age of onset, then it's fine to have a laboratory report the repeat number, but that's my opinion. Some people don't agree with that. So,
okay, yeah, that's helpful to hear your thoughts on that. Another question is, can the repeat expansion increase as the patient's age increases?
So if you do a genetic test and you get the repeat number reported to you, that's going to be the same, as you age. That repeat number is going to be the same. But there are differences in different cells of the body where they are going to be slightly different, but we're not sampling all parts of the body. So it really doesn't, it's not something you would know or find out over time. It's not really impactful. That's part of the reason why we think maybe that the number that you get from testing is not overall representative necessarily of what clinical signs you'll have, because it may be that that number is different in muscle tissue or something else that we don't test. And so so the number itself is, maybe different in different cells and things like that, but it's not something that you would see, like if you tested at 20, you would get one number, and then 40, you would get another number and things like that. It's not clinically part of the monitoring or management or anything like that. You would get the same number from age to age. So it really, in some sense, it doesn't really kind of matter what the numbers are in other cells and things like that, if that makes sense.
Yeah, that makes sense. Someone else asked, how does the CNBP gene fit into diagnosis? Their sister was diagnosed. Her DMPK was normal, and she was diagnosed based on CNBP only with greater than 75 repeats.
So I guess I'm kind of, so they did testing and it was normal.
Yeah, for their DMPK gene, and
okay.
She was diagnosed based on CNBP.
Okay. So we just want to make sure that there's a known genetic cause in the family and you're testing for the right thing. And if it's normal, then that person is not going to have that condition in the future. So I'm hoping I'm answering that question the way it's asked. So
yes, I guess I would just clarify and say, can you just remind us the difference between the CNBP gene and the DMPK gene, and how you can get different diagnoses depending on if you have expanded repeats in one gene versus the other?
That person may have done like testing for both myotonic 1 and 2. Some panels will offer like myotonic dystrophy testing, and it includes repeat numbers for both. But usually what we are doing is we're diagnosing the individual who has symptoms first and confirming that diagnosis, and then offering that particular test, test that's appropriate to other family members. So it's always important. It's as genetic counselors, like we might have someone come into our office who says, well, I have a family history of muscular dystrophy, or I have his family history of myotonic dystrophy. We want to know for sure who's been tested and diagnosed, who has had positive genetic testing for that particular test, so we know that we're testing the right thing in that individual. As I mentioned, there's hundreds of different types of muscular dystrophy. And so if someone just says, well, I have myotonic dystrophy in my family, I would want to actually physically see a copy of the report that shows that. So we encourage family members to talk about these diagnoses. We encourage them to share this information because it's impactful to other family members. We're coming up on the season of Thanksgiving. Thanksgiving is Family History Awareness Day. So as you're sitting down eating turkey, you can ask your family members if they have been diagnosed with anything that might be pertinent to you. I know it's not a fun conversation, but so yes, I mean, we would always want to say, okay, who is the person who's symptomatic? What test did they have? What confirmatory test? And even have a physically look at that test to make sure that the people who are at risk are testing for the right thing. And so, yes, tests are accurate, but if we're testing for the wrong thing, it's going to be negative. And so that's the challenge there. So I guess getting a copy of those test reports or asking family members who've been diagnosed to share that information is the best next step there.
Yeah, and I think this person, so you mentioned that someone may just be tested for myotonic dystrophy and have a test run to see if they have type 1 or type 2, and it sounds like that's maybe what happened in this case. And just to clarify, so DM1 occurs on the DMPK gene. Correct. And DM2 occurs via the CNBP gene. So in this case, this individual said their DMPK was normal, which indicates that they do not have DM1, but they were diagnosed with a higher repeat level on their CNBP gene, which would indicate a presence of DM2.
Yeah. So, okay. Yeah. Sorry.
No, that's okay. I think that's the information you provided is definitely relevant and valuable. I just wanted to add some clarification there in case that got lost in the weeds a little bit. But yeah, no, I think your advice is definitely applicable and helpful. And it's really important to make sure that you are getting the test that you need so that when you do get those results, they are interpretable in a way that makes sense for you and your situation. Mm-hmm. I know we're kind of looking at going a little over on time, but I just have one last question that has come in. Someone asked, besides repeat length, what other mutations, genes, or epigenetic modifiers are clinically looked at for myotonic dystrophy?
Clinically, we don't look at modifiers, but there are research programs that do what we call GWAS studies, and those are to look at why someone may have more severe or less severe symptoms, even if they have a repeat number that doesn't really quite match up to those clinical symptoms. So we know that everyone who has myotonic dystrophy type 1, for example, has a repeat expansion in the same gene, but not everyone looks the same. So you can take 50 people with the same exact repeat number, and they're not going to have the same age of onset, and they're not going to have the same type of symptoms or severity of symptoms. And so GWAS studies look at other genes and how they may either be protective or cause more severity in disease. So we're looking at outliers, people who are at the extreme, either somehow have very mild symptoms or somehow have very severe symptoms. And those have the potential to help lead us down the line of treatment. If you can modify or show that a gene can modify the expression of disease, then maybe you can mimic what that gene is doing. However, a lot of the treatments right now are focused on gene therapies and trying to turn off or edit out that expanded copy of the gene that is creating the abnormal protein.
Got it. Makes sense. Great. Thank you so much, Shawna. And thanks for staying on a little longer to make sure we answered all of the questions that are coming in. Thank you to our attendees for your participation. And just once again, thank you so much, Shawna, for providing this webinar. I just wanted to remind folks that this webinar is recorded and will be sent out to attendees within the next week. After the webinar ends, you will be provided with an option to take a short survey about today's program, and we would greatly appreciate you taking the time to provide us any feedback you might have. Lastly, if this program spoke to you, please consider showing your appreciation by making a donation via our website. You can also get involved by joining the Myotonic Dystrophy Family Registry as well. Thank you all for joining today's webinar, and we will see you next time.